And we'll take questions both online and here in the hall. And so let me just ask, first of all, are there any questions in the hall? And if I can just ask you to go over to the microphone so that the audience at home and online can hear you.
Thank you for your excellent presentation. I was wondering if there's, in the light of the funding cuts, if there's been any move in some areas to coordinate with parish nursing programs to provide personnel for testing.
I don't know that. I mean, I think we need to look at all kinds of options that can be used to continue the work. So that's an idea that could be taken up at local level. Thank you.
And I might add that in my own capacity at the Department of Health and Mental Hygiene, one of the things that Dr. McLean touched on was the issue of the state and local health department planning, and the state health department here, working with the Department of the Environment, is in fact planning to ask for public comments regarding some of the issues that Dr. McLean and Dr. Navasasian have mentioned, particularly in regard to how we manage, from a health department point of view, these low levels moving forward, and what to do about the issue of looking backwards at children who have been tested previously with low levels. Yes, madam.
So looking at the funding cuts and having experienced the frustration from a clinic perspective in identifying a child with only a 14 blood lead level and not being able to get any response anywhere for anything, what are the options for parents to be able to be proactive, know about how to test their environment and get access to materials to be able to test their environment, because they're not going to be able to find somebody else from the health department or somewhere else to come in and do testing, so that they can be proactive about their care and know whether or not their remediation efforts have been effective?
I think that's a great question, and I think health departments are going to have to find ways to make that information available, widely available, probably online through websites, and again, information that will enable parents to take action, not just general information about how children are exposed to lead, but specific things that they can do. And many health departments have that kind of information and have developed it. I think having a good package and making it available is probably one of the key steps that health departments, you'll see them taking.
Yeah, and I think one opportunity also to deliver that information, that package, would be through the contact with the primary care physicians, the pediatricians. No, I think it's sometimes a little bit frustrating to see that the test is administered sometimes as if it was a vaccine or something. Even vaccines, you need to provide information. No? There is not much information provided to the parent when you get those tests. Either when you get the test or even when you get the result, they just tell you, oh, you are fine, great, no? You can go home. And sometimes you don't get even that quantitative value of what your result was. There is just this, you are above or below the cutoff. And I think providing the quantitative values to know how far or close you are to the cutoff is very important for the parent, especially knowing that there is no safe level. And second, to know what can you do, even if there are risks in your house. So delivering that package at that care point of contact, I think, will be useful.
Sir.
So I have a very specific question. So how the early education may help the children already having higher levels of lead?
Actually, early education has been shown to be extremely effective in having children be successful in school, and it's very good. It's been seen as one of the ways we can invest in our society going forward, is to invest in early education for all children, especially at-risk children, but really all children. And my dissertation study also shows that children exposed to reading readiness education in school did well regardless of their lead level. And so I think that we have not done the studies to determine to what degree education can begin to turn around some of these effects, if it can. We don't know the answer to that, but we know that some children that had very high levels of lead have gone to college. Some of them are teachers. Some of them some of them are probably in this room. So those aren't just great individuals, but the families and the kinds of education probably that those children got, in addition to what they got at school, probably made it possible for them to be successful. Can we replicate that? That would be our aim. Our goal is to not just have low levels on screening tests, but all those kids that have been exposed to lead, we'd like them to be productive, like them to be employed, we'd like them to have successful lives. And we have to really think about the big picture here.
I believe we also have some online questions from our folks online.
We do. The first one I'd like to ask is kind of a technical question about blood sampling. The recommendation seems to eliminate an initial venous blood lead result as confirmatory. The recommendations state that you need to confirm a BLL above 5, even if initially a venous, due to the possible contamination. In practice, this means the child has to be tested twice with a venous. Can you confirm or comment this information?
That is what I understand from reading the guidelines too, and I think certainly this, I think we're talking about confirmation in 1 to 3 months is what the guidelines recommend for that too. Again, because there could be error in the result, and just want to see, is this a sort of a stable blood lead level? Was it elevated up to a 6, and then when you test in 3 months, is it down to a 2? I think really trying to figure out where the child is. And we know that testing at any one time, because the blood lead turns over, but if you have a lot stored in bone, you could continue to have a higher level or as high a level over time, but depending on the exposures. So I think that's the reason. I think it's a good question. I don't have a better answer.
Okay.
And I should just add that for capillary testing, which is more prone to contamination, the advice would not be to wait for 3 months, but to confirm it with a venous blood right away, because there is at least the possibility that that's an artificially increased test. So that applies to the first venous sample as opposed to a first capillary sample.
But I would say that even while you wait to have those results from the second test is to check if there are any obvious sources, meanwhile, just in case, not to also help.
And to this microphone, I believe.
Yes, obviously in some communities the housing stock's a big issue. And so what success, do you have any examples of some successful approaches to dealing with the old housing stock and being able to handle that exposure from that perspective?
Well, I think Maryland is a good example, and we are, and our law addresses rental housing, and doesn't require what we call full abatement, but now requires that rental housing has to be pre-50 housing has to be registered. It has to meet standard of care, which is free of peeling, chipping, flaking paint, and meet the dust standard. And we have another level in Maryland, which is that the properties will also meet, I believe, their 7 or 8 kind of standards for work to be done in the interior, particularly around the window and having cleanable, washable floors. I believe that our standard, while it hasn't prevented all elevations in blood lead, has helped populations, and we have seen many fewer cases in rental housing. I think another approach is the approach that's taken in Massachusetts, which requires full lead abatement in all houses, rental, owner-occupied, often very expensive, but they have an extremely effective program there where if you call and say, I have a child and we're living in a house with peeling, chipping paint, someone will come out and test that area with sodium sulfide. And if it's positive, they will take actions, enforcement actions, to get the property into compliance. So they have a mechanism in place there. I think it's very positive. So as we develop, as more houses kind of are torn down, older houses, and we get more new houses, we'll see probably less of this problem, although there's still often a problem of lead in soil where, you know, we have new houses built in older urban areas where there had been older housing. So I think, you know, I don't think there's a magic answer. I think states and mostly this is done at the state level, and state laws are really trying to look at, you know, how can we protect children and make sure that properties are safe, and what can we do? And there are probably as many answers to that as there are programs.
And I should mention also that the at the federal level, the new renovation, repair, and painting rule, the RRP rule that was promulgated by the Environmental Protection Agency, which is now going to be run in Maryland by the Maryland Department of the Environment, is one way to focus not so much just on the rental housing, but anyone who is going to be doing any kind of work where you're going to be doing major renovations. You are going to find that your contractor should be and will be trained specifically, and will in fact do those things that need to be done in order to prevent lead exposure and to reduce the possibility that your home in the future will have any problems with lead. So that's one area where you're seeing that we're again focusing on housing stock regardless of whether it's rental housing or owner-occupied housing. Another online question?
We do. This one is in regard to community gardens and lead in the soil in the community gardens. With the rapid growth of community gardens, what's being done to educate the public about the potential for lead in garden soil, especially in vacant urban lots? It seems there is no current standardization. Information on websites are either conflicting or out of date.
Good question, and I think it's a great opportunity for people to get involved in activity and also to grow food. I think many of the states that I have worked with in the past have been actively, there have been researchers and program people actively involved in the gardening movement to actually test the soil and make sure that soil is low lead level, often bringing in replacement soil. It is an issue, and certainly if we're redeveloping urban areas where housing has been torn down, we need to pay close attention to that. There are a number of options that have been evaluated in terms of having safe urban gardens, safe places to grow things in your yard, even if you have a heavily contaminated yard, as they do in Boston. But I think it's something we need to pay attention to.
From the research perspective, there are a few studies that have actually evaluated which plants absorb more lead from the soil versus which ones do not. So that could be quite useful in terms of what do you decide to grow. No, do you decide to have tomatoes versus carrots? Carrots are going to uptake much more than tomatoes. And then the other thing is also the research has also shown that if you eliminate the soil and put new soil, that helps. But that helps like momentarily, 1-2 years. And then it seems to kind of come back the old level. So this should require like that you do permanent surveillance and check and change the soil also over time.
So we'll take our final question, Madam.
Thank you very much. A very interesting presentation. As we talk about these very low blood lead levels to keep this surveillance, and I think primary prevention is a very important aspect. And I also trust that engagement of people in order to change behaviors, to take actions for something, it has a lot to do with the risk perception. People need to realize, to perceive, to give a value to their actions. So I wonder if you have, how are you dealing at this area of risk perception and the message? Because informing the public is one, but do they get it? Do they act based on this information? So if you can comment or, whatever, just one
Sure.
point that caught my attention. Thank you.
You probably want to comment too. I mean, I think when you look at the number of children impacted, when we look at a blood lead of going from blood lead of 10 to a blood lead of 5, we're we're looking at basically an 8-fold increase in the numbers, and it's still being unclear to healthcare providers and parents. My child has a 6. What does that mean? Should I be worried? I think a lot of people right now are very worried, are very scared. I think the providers that I've talked to, public health and medical providers, who are getting lots of calls in. People, I have a 6. What should I do? I'm worried. And so I think as we get clearer about follow-up and making sure that we're reducing exposures, I think it'll become clear. I think actually the current situation, people are more concerned because more people are in fact impacted, and it's clear now that this is something that affects a large percentage of children in our population, not just a small group that we could say, well, they're over there, they're not us. They are us, they're our children. And so I think this might have a good effect, but I think it's important that people know that 5 is not protective. No level is protective. And that's something that I think is hard to kind of get your arms around.
Dr. Navasasian, anything else to add?
I think it's just important to disseminate the information adequately, and I think in that sense the research studies are important because they are the ones that sometimes can tell people what's happening and which are the health effects that we are more worried or not, at which levels, and the dissemination of those findings. And so how do we do that, in which venues?
So I want to thank everybody for attending this Grand Rounds. Next month we'll be talking about influenza at the Public Health Practice Grand Rounds. And if I may take a personal note here, for the past 5 years I've had the pleasure of working with the staff at the Mid-Atlantic Public Health Training Center to put together the Grand Rounds. There's one person who really more than anybody else has been responsible for these monthly Grand Rounds and the success of this series. Molly Mitchell, and parenthetically, we are not related. Molly Mitchell at the Mid-Atlantic Public Health Training Center has really been the force behind this Public Health Grand Rounds series, and this is the last time we'll have the pleasure of working together as she's moving to a new position. So I just want to thank Molly for really being the person who, more than anybody else, has been responsible for a really astounding success of this collaboration between the Department of Health and Mental Hygiene and the Johns Hopkins Bloomberg School of Public Health. And for all of you online, I just want to say thank you very much for attending. We will be back next month, and thank you for attending.